Uh, Dear colleague, it's my great pleasure to introduce today's distinguished speaker from Japan, Professor Sunao Shoji. And Professor Shoji now is work at the Tokai University School of Medicine, and he is associate professor, and he specializes fusion biology, focal therapy, or HIFU. As I know, he has done quite a lot of HIFU uh, surgery in Japan, and nearly 1,000 cases. So I think his experience will show us how to perform the HIFU practice in Taiwan. So let's welcome Professor Shoji.
Thank you very much, C. Tongpan, Paul Fui Chiang, for the valuable opportunity. Li Ho, Hen Gaoxin, Jen Downing. And first of all, I would like to introduce myself. My name is Sunao Shoji from Tokai University, Japan. My specialty is prostate cancer, which including imaging, biopsy, robotic-assisted surgery, and focal therapy. Benign endoscopic surgery for BPH, prostate cancer biomarker, and medical economy. In my clinical experiences, I am a board-certified laparoscopic surgeon and a proctor for robotic-assisted surgery. In minimally invasive treatment for prostate cancer, I have an experience of 5,550 cases of MR transfusion image-guided biopsy, 400 cases of foreground HIFU, and 360 cases of focal therapy with HIFU. This picture is my university hospital. This is the main hospital. This is a research center and a medical school and nursing school. The standard management practices for localized prostate cancer are active surveillance and radical treatment. By the development of the imaging and treatment modality, the possibility of focal therapy for localized prostate cancer has come to be noticed. May I ask your opinion? Would you indulge me with your opinions? Please select the treatment as if you are a patient. There is no correct answer. He was 64 years old. His PSA value was 10.2 nanogram per ml. MR transfusion image-guided target biopsy and systematic biopsy detected significant cancer in apex and right peripheral zone. Please raise on your hand. Radical prostatectomy without nerve sparing. Please. No? Please raise your hand. Radical prostatectomy with left nerve sparing. Okay. So radiation therapy, focal therapy. Okay. After discussion, he selected radical prostatectomy without nerve sparing because this index region is very close to the nerve sparing in the apex. Next patient was 40 years old. His PSA value was 4.2. He has no previous history and family history. Prostate biopsy detected significant cancer in left peripheral zone. And his score of IIF5 was 23. Please raise your hand. Radical prostatectomy without nerve sparing. Radical prostatectomy with right nerve sparing. Radiation therapy. Focal therapy. Thank you very much. He selected focal ablation for this target. Next patient was 17 years old. PSA value was 9.2 nanogram per ml. Owing to his bilateral osteoarthritis, he had difficulty in visiting the hospital regularly. The biopsy detected significant cancer in left peripheral zone like this. Please raise your hand. Radical prostatectomy with nerve sparing. Radical prostatectomy with light nerve sparing. Radiation therapy. Focal therapy. Thank you very much. He selected focal therapy with left hemiablation. As you can understand, because each patient's circumstances are unique, focal therapy would potentially have a role in select patient. This slide shows my recent week. Monday, outpatient clinic and MR fusion biopsy. Tuesday, 2 cases of focal therapy and thulium laser enucleation of the prostate. Wednesday, outpatient clinic and MR fusion biopsy. Thursday, robot-assisted radical prostatectomy and outpatient clinic. As you can see, the number of focal therapy and robotic surgery was similar in my institution. This is today's agenda. At first, I would like to present current status of focal therapy for localized prostate cancer. In EAU guideline 2022, focal therapy was recommended to be offered within a clinical trial setting or well-designed prospective cohort study. However, it is hoped that more mature and robust data demonstrating long-term efficacy in the next few years will provide the necessary evidence which will facilitate its wider implication and acceptance. The following conditions need to be met before focal therapy can be accepted as a standard treatment for localized prostate cancer. Survival efficacy at least equivalent to standard of care. Fewer complications and functional side effects compared with standard care. Reliable follow-up of remaining prostate tissue. Potential secondary or salvage treatment not impaired by primary focal therapy. In previous peer-matched study between radical prostatectomy and focal therapy, 5 years failure-free survival rate was 82% in radical prostatectomy and 86% in focal therapy. The failure-free survival rate was defined as need for salvage, local, and or systematic therapy or metastasis. In previous clinical studies of salvage LARP after focal therapy, toxicity of surgery after focal therapy is low with similar urinary and sexual function to primary cases of LARP. Oncological outcomes were similar to those of primary LARP. In our experience of salvage LARP or salvage IMRT after focal therapy, toxicity and short-term oncological outcomes were similar to primary LARP and IMRT. This slide shows the treatment range of focal therapy. At the start of focal therapy, pocket stick and urethral sparing ablation were reported. However, recently, treatment range was reduced, such as this. Next, I would like to present a modality of focal therapy for localized prostate cancer. This slide shows the representative modalities of focal therapy, which had long-term results in foreground therapy. High-intensity focused ultrasound HIFE can treat inter-targeted area with a distinct margin between the treated and untreated adjacent treated area without needle insertion. And the HIFE has advantage in the treatment for the target located in the peripheral zone. Brachytherapy and cryotherapy required needle insertion. And because of radiation therapy and formation of ice ball, it is difficult to treat with a distinct margin between the treated and untreated area. However, these treatments have advantage in the treatment for the target located in the anterior portion of the large prostate. In terms of cost, brachytherapy and cryotherapy required equipment installation. And in running cost of HIFE, brachytherapy, and cryotherapy, $6, 2,000 US dollars, and 5,200 US dollars respectively. Hospitalization after treatment of HIFE, brachytherapy, and cryotherapy was within 24 hours, 2 days, and 2 days respectively. Next, I will present development of the technique and technology of HIFE. HIFE produces ultrasound waves generated by a spherical transducer delivering ultrasonic energy to pinpoint millimeters in diameter. The thermal and mechanical effect of HIFE destroy targeted prostate tissue. A distinct margin between treated and adjacent untreated area is observed in the prostate treated with HIFE. These characteristics make HIFE an attractive therapeutic modality for the focal therapy of the prostate to cure while preserving continence and erectile function. Japanese national broadcast NHK interviewed and broadcast out the technique of HIFE. This gentleman is Shinobu Sakagami, very famous personality in Japan. Please start the movie. Can you start the movie? Yes. I introduce the part of the TV program. This is a HIFE probe. This is a spherical transducer as I presented. At first, I treated chicken. Yeah. So also, there was no change in the on the surface, but in the treated area, in the chicken was coagulated like this. Next, for the confirmation of the planning, I treated plastic board. As procedural planning, the word of Sakagami was ablated on plastic board. The protocol of focal therapy with HIFE consists of location of significant cancer, technical development of HIFE, and development of HIFE device. Location of significant cancer is very important. Combined of MRI transfusion image target biopsy and systematic biopsy are able to detect 90 to 95 of the index lesion. In technical development, in our clinical experience of foreground HIFE, prostate swelling and intraoperatively observed on real-time truss imaging. This figure shows the before the treatment and the after treatment for anterior zone in same patient. We measure the change of the prostate volume and intraprostatic point shift before and after the treatment in 44 patients. During the treatment for anterior portion for median 25-minute treatment, median 80% of swelling and median 3.7 millimeter shift was confirmed. In histopathological findings of prostate tissue treated with HIFE, coagulative generation of prostate cancer tissue involving gland and vessel with diffuse stromal edema was diagnosed. How can we control intraprocedural prostate edema for accurate focal therapy? So we came up with compression stocking for edema. We started the compressor prostate from the rectum by the HIFE probe interprocedurally, so-called compression method. We compared the change of the prostatic swelling and interprostatic shift between the conventional and compression method. In compression method, balloon was expanded by the water from 80 to 200 millimeter. And rectal surface and rectal ultrasound crystal was set parallel at the distance of 10 to 30 millimeter depending on the size of the prostate. As you can see, a prostate is compressed significantly in our method. During the treatment for anterior portion, the median 21% swelling and 4.0 millimeters shift were confirmed in conventional method. However, median 5.5% swelling and 2.0 millimeters shift were confirmed in compression method. Further, on contrast-enhanced MRI 2 weeks after treatment, blood flow was remained in the anterior portion in conventional method. However, in compression method, totally blood flow was disappeared. I show you the clinical result of foreground HIFU at our institution. The patient, between the patient treated with HIFU with and without the compression method, biochemical disease-free survival rate was significantly different. Biochemical disease-free survival rate of the patient with compression method in low, intermediate, and high-risk group were 88.2%, 77.2%, and 67.1% respectively. Sonoblade device has been developed. Using 3D treatment planning, focal therapy can be planned on axial, sagittal, and coronal ultrasound images. Tissue change monitoring can predict intraplastic temperature during the procedure on real-time ultrasound image. So safety alert system can prevent rectal injury. Next, I will present clinical study of focal therapy with HIFU for the patient with localized prostate cancer in Japan. The first 90 experiments of our institution already published. Now, more large study is ongoing in our institution. I will present a part of this clinical study. This is inclusion criteria. The PSA level with and less than 20 nanogram per ml. Significant cancer should be located using MRI transfusion image targeted biopsy and systematic biopsy. No bilateral significant cancer. The focal ablation was performed based on the 3D location of the significant cancer with a 5 millimeter margin. Please start the room. For the accurate treatment and accurate 3D planning, the location of the significant cancer and its relation to the intraplastic structure was evaluated using software. And transferred to the HIFU monitoring like this. So during the procedure, the output power was adjusted to be observed hyperechoic region, so-called popcorn phenomena. So you can see the hyperechoic region like this. This is a sign of a successful treatment. In post-procedural management, urinary catheter was removed within 24 hours after treatment in all patients. NSAID were rarely used for the patient after the treatment. In follow-up, contrast-enhanced MRI was taken at 2 to 4 weeks after treatment to evaluate blood flow in the treated area. PSA, function, and quality of life were measured at every 3 months after treatment within 24 months, and every 6 months after treatment after 24 months. MRI was taken every 6 months after treatment within 24 months, every 12 months after treatment after 24 months at biochemical failure. MR transfusion image guided biopsy and systematic biopsy was performed at biochemical failure. Based on the insurance situation in Taiwan, these MRI can be omitted from the clinical study, I think. This is a definition of recurrence. Biochemical recurrence is defined as a Fink's Astor definition. Pathological recurrence was diagnosed using MR transfusion image target and systematic biopsy at biochemical recurrence. On contrast enhanced MRI at 4 weeks after treatment, the blood flow was disappeared in treated area. Further, we confirmed the disappearance of their blood flow three-dimensionally. In patient characteristics, the patient number of low, intermediate, and high-risk group was 54, 71, and 78 patients respectively. PSA, prostate volume, and glycol score are shown here. In periprocedural data, the median procedural time was 54 minutes, and median hype ablation time was 30 minutes, and median treated volume was 14 cc. In oncological outcomes, biochemical recurrence-free survival rate was 88.7%, and pathological recurrence-free survival rate was 90.1% respectively during follow-up of 36 months. In the first 100 cases, we performed routine biopsy to confirm treatment effect at 6 to 12 months after treatment. However, recently, routine follow-up biopsy was avoided in the patient whose Pilates category less than 3 and PSA density less than 0.068 nanogram per ml after focal therapy based on our experience. Regarding oncological outcomes, the median decreased rate of serum PSA level was 80% of the PSA. The biochemical recurrence tended to be lower in the patient with greater PSA decline. However, some patients were diagnosed with biochemical recurrence. Some patients don't show biochemical recurrence with small reduction in PSA value. For example, treatment limited to peripheral zone in large BPH. So PSA has a limitation to evaluate the effect of focal therapy in our experience. This slide shows a long change of the scores of urinary function and erectile function. So these functions deteriorated significantly at 1 month after treatment, but improved to at 3 or 6 months after treatment. The complication is very lower than that of foreground therapy. Urinary structure was 3.4%, UTI was 20%, and urinary incontinence was 1.5%, and severe erectile dysfunction was 24% respectively. I would like to present a good case of focal therapy. He was 63 years old. PSA level was 10.28. On multiparametric MRI, cancer susceptible lesion was diagnosed in left peripheral zone. The biopsy detected significant cancer only from this area. So we did focal therapy with HIFU. Ablation time was 22 minutes, totally 55 minutes treatment. After the treatment, blood flow was disappeared in treated area like this. This is a PSA change for this patient. So there was no elevation of the PSA level during the follow-up of 54 months. This longitudinal change of the score of urinary and erectile dysfunction, the patient's score was deteriorated at 1 month after treatment, but improved at 3 months after the treatment. Finally, I would like to introduce our clinical research to evaluating risk factor for contemporary deterioration in urinary function, severe erectile dysfunction and to analyze biomarker for the evaluation of treatment effect of focused therapy. In the evaluation of risk factors of contemporary deterioration in urinary dysfunction, there was a greater risk of urinary dysfunction with treatment is bilateral anterior TZ portion than in other portion during the focal therapy with HIFU. In the risk factor for severe erectile dysfunction after focal therapy, procedural lower score of IIF-5 and sexual domain of the epic and treatment of edge of the peripheral zone proximally to the neurovascular bundle was the risk factors. This is a biomarker study. We focused on the difference in the sugar change of the PSA from normal and cancerous prostate tissue. LDN PSA is a PSA carrying a prostate cancer associated sugar chain. On multivariate logistic regression analysis to predict the detection of significant cancer in the patient with highest PIRATS category 3, age and LDN PSA density are significant risk factors. So LDN PSA has possibility to contribute assess effects and recurrence after focal therapy for localized prostate cancer. Take-home message. Development of technique and technology would contribute to improve the clinical outcomes of focal therapy with HIFU. These clinical outcomes of focal therapy for localized prostate cancer in Japanese patients is promising for long-term results. Further large studies are required to verify oncological and functional outcomes from this treatment for patients with localized prostate cancer. It is breaking news. Ministry of Health, Labor and Welfare approved focal therapy with HIFU as an advanced medical care in February 1st this year. Thank you very much.
Thank you, Professor Shoji. I think he's not only a robot surgeon, but also an imaging guided therapist. He's the best candidate to present the HIFU. And any question from the audience? I have a question. I'm very interested in your compression method. What's your maximal prostate volume? And do you think for the candidate of HIFU, maximum volume?
So in focal therapy, so size is out of the planning because if prostate cancer located in the peripheral zone, no limitation of size. But if prostate cancer located in the anterior portion, maybe over 50 millimeter prostate is limited for the focal therapy using HIFU, in my experience.
Yeah, I find your case maximum is 59 mil.
Okay.
Do you think about the TUP instead of compression method to treat the patient if they are cancer localized over the anterior portion?
Maybe using compression method, the candidate for the prostate candidate of the patient would be widened, I think.
Why I ask you, because in Taiwan we also use the TUP in combination with HIFU.
Okay.
听众有没有什么问题? And that's the question. If your family or your friend suffer from localized prostate cancer, what kinds of surgery will you suggest?
Oh, excuse me?
If your family or your friend, best friend.
Okay. Based on the location and Gleason score of the significant cancer.
For example,
yeah.
3+4 Gleason score and localized one side. And
of course, focal therapy.
Focal therapy.
Professor.
Thank you.
Thank you very much.